Good evening and welcome. My name is Jim Greenblatt and founder and medical director of Psychiatry Redefined. By way of introduction, if you don't know me, I've been practicing psychiatry for 35 years. I first starting thinking and writing papers about nutritional and metabolic psych about, hate to say, 40 plus years ago, um, as I was in college. Had no concept of that I'd be a psychiatrist. But for many, many years, I've been embedded in the field of traditional psychiatry, running inpatient units, residential programs, eating disorders, addiction, and general psych. And I've had a dual career training doctors in integrative and functional medicine for at least 30 years. So, what I bring tonight is an introduction to our fellowship programs, which is we do them twice a year, and these are year-long trainings. We have a general fellowship. I think this could be the ninth year of this organized fellowship. I've been teaching this material around the globe for 30 years, but the general fellowship and the pediatric fellowship, this is our second year. And these are year-long programs where we take you through clinical protocols, deciphering this amazing information overload with how to help patients. So during the spring, we do these series of webinars, and I get the fortune of sharing mine tonight, moving beyond symptom management, an introduction to functional, nutritional, and metabolic psychiatry. So I'm going to, the other, I was going to name it, understanding the role of nutrition in health is not alternative medicine. One of the things that I tell everybody who takes our programs or in our fellowship, you can never use the word alternative medicine again. What I will share with you tonight briefly is just a summary snapshot, but what our curriculum has of 450 hours of content is not alternative medicine. It's what most people will call good medicine. And we'll discuss a bit about it. So I'm going to just ask two questions tonight. And then if you feel comfortable in the Q&A, please ask questions. And I'll answer as many as I can. So you can put those in the Q&A. But in the chat, I have two questions. And this picture is not to lead anybody, but I just wanted to get a sense if anyone feels comfortable just putting in the chat why you signed up for this webinar. What was it about this title, Moving Beyond Symptom Management, Introduction to Functional Nutritional Metabolic Psych? What was it that prompted, maybe I'll listen to this guy, or what is this all about? Anyone wants to just throw a few comments in the chat that would love to kind of hear. Okay. Dennis wants to be able to integrate approach into private practice. So patients on medications like clozapine, how to integrate it, learning something new. Found other webinars helpful. To help clients, something new. Okay. Coordinating with different medical specialties. Okay, so This is a group that wants to learn something, and I will share as much as I can. I really appreciate you taking that time, but I kind of use this image because so many of the people we're training now are frustrated, trying to sift through the information in nutritional and metabolic psych, the information overload that's legitimate research, the pharmaceutical distortion sometimes of the research, the media distortion of the research, and then some of the influencers distorting the research. And many clinicians have just shared with me the conference or the webinar is great, but it's really hard to know what to do the next day, the next patient. How much magnesium? What's the interaction with the antihypertensive medication? And so I sometimes use this image for what our patients feel like sometimes in our current psychiatric model, which we'll talk about, but also what more and more clinicians are feeling like in terms of how do I get all this exciting information from psychedelics to ketamine to understanding vitamin D into a clinical practice. So that's what we're going to chat about, and that's what the fellowship is. So this is why I am here tonight, and why I keep doing this is I don't need to go through all these statistics, but this one, when it came out a couple of years ago, it just really upset me terribly as a child psychiatrist, as a parent. But 20% of high school students in 2023 reported seriously considering attempting suicide in the past year. Now, not the 40% that were sad and hopeless, and you and I might have called depressed, 40%, but we're talking about 20% of high school students surveyed. This is a CDC survey. Not a suicidal thought, seriously considered attempting suicide in the past year. So that's why I'm here, and that's why I'm quite confident practicing in conventional psychiatry, training residents, training nurse practitioners, and training integrative doctors. I am confident and 100% sure that an integrative functional and metabolic strategies outcomes improve dramatically. We just can do better. So we got to work together to figure out how. So I like to just kind of, when people ask me about the mental health crisis, the numbers, the epidemic, I try to kind of shift the discussion that it's not a crisis of numbers, that I hope to share with you a little bit tonight, that this is a crisis of our model of care, of our mental health care model. And that's what we have to change. And that's what functional psychiatry and Psychiatry Redefined is all about. So I'm going to just turn off my camera during the presentation and I'll come back. Just be a little easier to focus on the slide. So this is Psychiatry 2025, right? I saw this Christmas time last year. Holiday brain boost, 25% discount. And wait till the psychedelics get approved. But I just feel that this is not good psychiatry. I was walking through Brooklyn and I must have walked by 4 or 5 ketamine clinics, within a half a mile. Huge signs trying to get people off the street. And then I saw this advertisement when I got back. So I don't think this is the answer to all of our mental health challenges. And maybe you agree. So, as a card carrying practicing psychiatrist in the field for a long time, I can say that our field is pretty much educated guessing. There's nobody on the planet that can tell you um, that it's anything but. Now, the better educated you are, the better guessing you can make. But the fun part about training residents from different programs around New England, I ask them about what antidepressants they use or what antipsychotics, and they all have a favorite and they all have a reason. And it's because their supervisor told them, but they're all very different. From four different programs in Massachusetts for a depressed patient who's sedated, everyone's going to give them a different medication, and they have their reasons. Some of it's jargon from the pharmaceutical companies, some of it is clinically relevant. But what we're going to learn tonight, and what is the core concepts in everything we do in Psychiatry Redefined, is this concept we'll talk more about called biochemical individuality. Everyone's different. So I worry about the ketamine discounts for Christmas. I worry about educated guessing and this fast food mentality where symptomatic-based medicine. And what Psychiatry Redefined has done over the past 10 years is develop a curriculum and faculty. We have, I think, 35 now, but growing. We always get new 35 faculty. We have people who've joined the program from over 16 countries around the globe. And we define functional psychiatry as nutrition, genetics, lifestyle, therapy, hormones, and medication. It does not mean you have to throw away your prescription pad to understand and integrate functional and integrative psychiatry. So it is a holistic program, but it's focused on root cause. And this is from my ADHD lecture, but I stole it because I just really liked it. Because think about the last few patients that you've seen, um, right, with a mental health challenge. And most of the time, you're using this term, why don't we try this, right? You're choosing Prozac, Zoloft, Paxil, Effexor, Prestige, or I've seen people going to second generation antipsychotics to start. But regardless, you're making that educated guess. And functional psychiatry just takes the biology, the genetics, and just changes the trajectory. That every patient that has a functional psychiatry evaluation, we don't guess, we know. And we'll talk more about it, but that's the goal. And how do we get into this mess of educated guesses? Because we've shifted pretty far from our medical model. What happens in any other medical specialty, right? From the orthopedic, from knee pain to chest pain to this guy's got a sore throat. You get to the practitioner, they're going to examine you and they're going to do objective testing. Is it strep? Is it COVID? Is it tonsillitis? Whatever it is, that those objective tests are going to determine the treatment. And the treatment is targeted. And then after 10 days or 2 weeks, whatever the course of the treatment is, you're going to look again. Is the throat red? Is it pustule? And that's our medical model. Think of chest pain. Is it cardiac? Is it panic? Is it pneumonia? We're going to do objective tests. Think of any time you went to an ER or brought your child or your spouse or urgent care or even your PCP. It is based on objective testing and treatment. But what have we done? We came up with this, I don't know how many 1,000-page manual with a list of symptoms. Now, when you really start thinking about this, and I need you to do it tonight, a list of symptoms, and that makes the diagnosis. There's ask a lot of questions. Maybe now you have computerized forms, and the computerized form spits out a diagnosis. Depression, oppositional defiant disorder, panic disorder. And then you give a pill or two based on the symptom. So if you're feeling sad and hopeless and not sleeping well, you're going to get an anti-sad, not sleeping well pill. We call them antidepressants. And we're going to ask you 3, 6 months later, how are you doing? But that model of symptomatic based medicine can only lead to one model of care, polypharmacy, because you're never going to hit every symptom because there's no concept of etiology. So you add the second medicine or the third or the fourth or the fifth. I mean, it's pretty much out of control, and sometimes the medication for the side effects of the first. So that's what we've been dealing with, and no physical exam, no objective testing. I talked to psychiatrists and nurse practitioners in rural clinics and community clinics, in prison populations, and certain hospital settings where they are told, the mental health clinician, that they are not allowed to recommend or order lab testing. That's for the primary care doctor, the once a week consulting. It's not the role of the psych person. That's to prescribe only. And I will get in the end how this is a certainly breach of our ethical and moral obligations as mental health clinicians. So I'm going to stop whining soon, but this was an article I saw a couple of weeks ago. And there's a committee, the APA is a committee that's working on the next DSM, right? And they're going to try to make it more holistic. And but the biomarker, which is a core concept of functional psychiatry, they proceeded to say that the next DSM, DSM-6, will not have any biomarkers because we don't have the data. They're going to make it a living document, whatever that means, but there's going to be no biology. There's going to be no etiology. It's going to be a list of symptoms made more comprehensive. And this is the fundamental problem with our model and outcomes and relapse rates. And for many, I believe, a view of frustration of being placed in a poor polypharmacy model because we know that's not the cause of all mental health is a deficiency of Prozac or Effexor. But we do know, and we've known for 50 years, if not longer, if we take any mental health symptom or diagnosis, let's do depression tonight. So depression is the top of the tree. What are the causes? We know in environmental toxins, cadmium, copper, mercury, lead. We know gut dysbiosis. We know infections, Lyme, other tick-borne illnesses, COVID. We know vitamin deficiencies, B12, folate, D, all can contribute to depression. We know stress and trauma. We know insulin resistance. And we have a huge number of genetic vulnerabilities that contribute to depression. MTHFR variants, TT, the 67T variant, higher likelihood of depression. So we know all that. What about iron deficiency anemia? What about low thyroid? What about low testosterone? So we could probably make a list of 20 things that could cause depression. And these are things we might have had to answer a multiple choice test when we took our boards. What causes depression? Because this is what we learned in school. I'm going to focus on iron deficiency anemia for a little bit because I saw an iron deficient individual who was depressed and lack of motivated and in her 30s, and no one looked at iron ferritin. But what happens when we get out and practice? We forget everything we learned because we don't do objective laboratory tests. We simply provide a treatment for that symptom. So this will be one of the most important slides of tonight. This pathway of biochemical individuality. Oh, doesn't want to stay. Let's take 5 young women in their 30s presenting to you with poor sleep, ruminations about work, feeling like a failure, stressed, eating more, sad, fleeting thoughts of hopelessness, helplessness, and at times in bed wished she was dead. All the same symptoms. So depends if you take an hour or 10 minutes, all of you would probably come up with major depressive disorder. And based on what I just shared with you, Debbie is going to have could have a different underlying cause of Deborah, Debbie, or Debs, right? All the same age, all the same symptoms, sorry. And in your office, in my office, in my hospital, in my treatment programs, most clinicians are going to find their favorite SSRI and prescribe it. How many of you are going to look at, let's just name 5: thyroid disorder, hypothyroidism? How about, again, low iron? How about B12 deficiency? How about elevated copper and low zinc? Okay, and this excludes all the psychological stress and trauma that we know can cause depression. But magnesium, zinc, folate, thyroid, iron, elevations of cadmium, mercury. What about a chronic infection? What about mold toxicity? What about mast cell activation syndrome? The list is endless. The point is, are you looking? And people always ask the difference between functional integrative medicine. Functional medicine, for me, is that digging deeper, looking at genetic testing, looking at lab testing, trying to understand that genetic vulnerability and environmental insults that are contributing to that patient symptoms, root cause. And the integrative medicine, that has reached our academic circles. Stanford, Harvard, Duke, all have mindfulness training. You can get fellowships in lifestyle medicine and learn about sleep and exercise and ultra-processed foods are not good for you in a 2-year program. You can take mindfulness courses and spirituality courses and cooking courses now in medical school and yoga classes. And that is incredible. And it's supported by the research. We know. But for too many of our psychiatric patients, it's just not sufficient. And that's why in a personalized medicine approach, in a functional psychiatry approach, you just need both. You need integrative and functional medicine. And the new one that didn't fit on this slide, we're calling it metabolic psychiatry now, right? With the explosion of research on insulin resistance and ketogenic diets, it has a tremendous, tremendous opportunity to help a lot of those with mental illness. And Psychiatry Redefined was one of the first groups to start teaching ketogenic diets and mental health. We had conferences 5, 6 years ago. I think the last article I wrote, I just cautioned everyone, just like ketamine and psychedelics, it's not the cure-all. It's not easy, particularly for young adults, to comply, and but it's an incredible tool. And if we can regulate insulin resistance and blood sugar spikes, we can help a lot with mental illness. My one comment about ketogenic diets and metabolic psych is think about what is being eliminated on these diets. These diets all eliminate gluten, grains, ultra processed foods. I'm quite convinced of the thousands of patients I've seen that much of the benefit is not being in a state of ketosis, but it's avoiding um, gluten and ultra processed foods. I think there's tremendous growing research on gluten. We're going to touch a little bit about it today. But that's the big picture. Let me give you a few examples of functional psychiatry, and we'll talk about vitamin D, amino acids, and lithium, and then celiac, and then answer your questions. So Larry was 32 when I saw him, depressed since college, could never stop one medication, so had multiple medications. Family had the means to take him to doctors, traditional doctors on the West Coast and the East Coast, integrative doctors around the country, and nothing really helped. Trials of multiple meds, as well as really important to understand family history, bipolar disorder, and addiction. And this was a partial list of his supplements that he came to see me. And I really mean partial because I couldn't fit them all on one slide. So every doctor he went to gave him a handful of supplements because they did this one test and they said you should take, they did a neurotransmitter test. They said you should take GABA, and someone did a vitamin D test that you should take this. And then he read that, NADH is going to be really good for me. So this was just a hodgepodge of what Larry and his family was trying to do for many years by seeing the best professionals around. And again, this list was short, but we did our functional psychiatry workup. We looked at, trying to move this so you can see, we looked at Larry's amino acids and fatty acids and micronutrients, and he was eating a very healthy diet. Actually, I forgot to say that he was, again, financially sufficient, well off to buy the organic fancy foods. But if you look at the top of this test, these are amino acids, the essential amino acids. That red squiggly everything to the left is low. So he's profoundly deficient in essential amino acids. These are the precursors to all the neurotransmitters, the dopamine, the serotonin, the norepinephrine. You see, where's tryptophan? Low. Phenylalanine, low. Those are the building blocks of dopamine and serotonin. So something didn't make sense because Larry was eating adequate protein, but we did a functional medicine test that showed that he wasn't absorbing it. So, sorry. So what did we do? Well, we had to provide Larry one with the amino acids, free form amino acids. And it doesn't mean eating more steak, right? Because he was eating adequate protein. He just wasn't absorbing it. So we had to give him just the amino acids, free form amino acids. And then we gave him digestive enzymes with hydrochloric acid. So we could break down that expensive organic food that he was eating. And the free form amino acids can help someone in a few weeks, and his digestion improved over a couple of months. And we were able to safely taper Larry off the antidepressants and treat his depression. Anyone with this pattern, low levels of all the essential amino acids, are poorly motivated, very depressed, sometimes having anxiety. I mean, it's not always simple, but this was a complicated case that turned simple because we had other tests that were completely fine. So the macronutrients, protein, amino acids, critical for mental health. What about the fats of life? 60% of the dry weight of the brain is fat. Our obsession with low fat, no fat since the 60s, not only has it not affected heart disease, but I think has profound consequences for our mental health challenges, our mental health problems. The brain is the most cholesterol-rich organ in the human body. Most of the cholesterol in the body is not from what we eat. Our liver makes 85% of it. We get a little from our diet, but the brain is a fatty organ. Well, let me just keep going for a minute. Cholesterol, right? It's the precursor to every steroid hormone in the human body. Is a precursor to vitamin D. So nothing works without cholesterol. So to think of this evil demon that we labeled in the 60s and tried to eliminate it has profound implications for mental health, particularly those who are genetically prone. Just go back a second. What did I say? Every steroid hormone, the progesterone, the testosterone, the estrogen, the cortisol, the DHEA, the pregnenolone, it all comes from cholesterol. Vitamin D, I'm going to talk about in a few minutes. Cholesterol, bile acids, cholesterol, stabilizing serotonin in the brain, cholesterol in the membrane. It's kind of important. And what clinically, we have 30 years of research, and I've seen it in my inpatient work for 30 years, but everyone ignores it. How many do you know? You can put this in the chat. I'd love to see that very low cholesterol, total cholesterols, under the research is under 150, but I use the term under 120 is associated with increased depression and suicide. How many of you have heard that? How many of you act on it? How many of you look for this? A better question is how many inpatient units even draw lipid panels? Because most inpatient units, certainly ER is not going to look at a lipid panel if someone comes in suicidal. Most inpatient units, all the lab costs are eaten by the hospital. The insurance doesn't pay. So they're not going to be drawing lipid panels because that has nothing to do with psychiatry. But these are, this was a gentleman I admitted to our inpatient unit. Luckily, I was in charge, so I made everybody order lipid panels, and it cost us money. But in the 2 months following my lecture to the staff, the medical staff, these are 3 cases we saw. This one boy, 18-year-old, multiple suicide attempts by hanging, total cholesterol. This is not HDL or LDL or any fraction, total cholesterol, 69. And then we had 2 other kids come in, 119 and 110. And these are not vegetarians or vegans who are avoiding fat. These are kids eating McDonald's and French fries and milkshakes. It's unclear the mechanism, whether it's an infection or just genetic. Most people think it's a genetic vulnerability. But either way, since 1994, people have been trying to kick and scream and say there's something wrong when you have a cholesterol of under 150. And the research is consistently, and everyone keeps telling me about these negative studies, but no one has ever sent me one. There's some that were not as positive as others, but low cholesterol increased suicide risk. And again, 30 years of research. Here's one, females, 2025, cholesterol and suicidality. Now, the research is extensive. We have courses on this. And then just to make it more interesting, we have autopsies. And if we look at the brains of those that completed suicide compared with age-matched controls who died of motor vehicle accidents or non-suicide, less cholesterol in the brains of those completed suicide. So cholesterol is critical for the serotonin stabilization of the serotonin receptor in the brain. So long story, but important part of functional psychiatry. And this you've heard more about, so I'll go through quickly. The omega-3s, that's good, right? We can't talk about cholesterol because those are evil molecules, even though the building blocks of life. But omega-3s has gotten more press for longer. We know that essential fatty acid deficiency, particularly the omega-3s, inflammation, aggression, depression, psychosis, chronic inflammation in the gut, anxiety. This has been known for a long time. And again, this is a 2-hour talk, but low dietary intake, greater risk of death from suicide, higher risk of depression, and suicidal thoughts. Omega-3 literature is extensive. And whenever you get a negative study, we'll talk about this with vitamin D, it gets a lot of press. And usually, if you're in a training program, that's what the attendings will quote is that one negative study, which is kind of mind-boggling because I have like 22 studies that might say, I'm just making up that number, I'm sure there's hundreds, but let's say I have 20 studies that low omega-3s associated with major mental illness, depression, suicide risk, a lot of it done through NIMH and some defense grants because they were worried about suicide in the military. And we get one study that said that those results were not accurate. But it's that one negative study in the nutritional psychiatry world that gets the headline, that's our attendings quote, and people are forgetting the other 20. So the brain is 60% fat, it's critical. All you have to do is think of my poor patients. I spent 25 years on inpatient eating disorder unit with anorexia nervosa patients who have restricted the intake of fat for their entire life, some for 2 years if we catch them early, some for 30 years. And that fat restriction has resulted in a disease where we have no medications, the highest mortality rate of any psychiatric illness, the highest risk of suicide for any psychiatric illness, the most treatment refractory, and the highest risk of relapse. It's a fat deficiency disorder that's never addressed as such. So, how about if we turn this around and say 70% of Americans are deficient in vitamin D, right? We're inside, sunscreen, clothing, it's just a problem. And, we think of vitamin D and bone and calcium absorption. Now we think about it with immune regulation, but somebody has to get back into this equation. Vitamin D has significant implications for brain function. It is the rate limiting factor in the synthesis of serotonin. Okay, that tryptophan hydroxylase enzyme, which is the rate limiting step in the conversion of the amino acid tryptophan to 5-HTP, that's activated by vitamin D. Nothing happens in the synthesis of serotonin without adequate vitamin D. And I know many of you have seen vitamin D levels 5 and 10 and 8 or 13. I mean, anything under 50 we're concerned about. Anything under 30, I think has profound implications for mental health outcomes. So 70% are deficient in vitamin D. 70% are not adequately making serotonin. It has major mental health implications. And it's really that simple. Vitamin D deficiency, you're not making tryptophan hydroxylase enzyme, it's actually number 2 for the brain. Serotonin synthesis is decreased. And depending on your genetics, you can get depressed, anxious, dementia. And the research, again, goes way back, but I just picked some of the 2025 studies. 500,000 individuals Vitamin D deficiency and suicidality, much lower. And we have studies going way back, probably 10 or 15 years before that. In the military, everybody gets their blood drawn before they go. Those that completed suicide had low levels of vitamin D. Those that attempted had low levels. And I think there was one vet study where they looked at charts and people that took vitamin D had improved suicidality. Here's some, again, new research. Um, Suicidal patients, 14 to 46. Almost half were found to be suffering from vitamin D deficiency. Okay, so this I mentioned a little bit earlier, but just to kind of reiterate, if you jump into this nutritional psychiatry world, some days you need your boxing gloves on because everyone's out to prove us wrong. Even though I can say a few times tonight that after 30 years, we've been proven right about all this work looking at nutritional deficiencies in brain function. And I'm glad that you're here to listen. But this is what you're going to find. Again, the same thing I mentioned. Vitamin D did not help depression. That's the headline. That's what is the press release. That's what gets covered. Okay, but those studies just gave everyone 100 people vitamin D, probably a very low dose, and nobody looked at levels. And just like every other micronutrient, and the core concepts of functional psychiatry is not everyone is deficient in vitamin D, not everyone is deficient in omega-3s, but some are, and has profound effects on mental health. The research on vitamin D is quite overwhelming. Low vitamin D is associated with depression, anxiety, suicide risk, and dementia. Indisputable, all those topics. Okay? So here, if we have very low vitamin D in Johnny, got a level of 12, guess what? His mood is going to get better. Therapy is going to work better. Meds are going to work better. Other supplements are going to work better. But Jack had a vitamin D of 48. So giving him a small amount of vitamin D is not going to make a dent in his depression. Again, we just keep coming back to this concept of biochemical individuality. Everyone's different. Okay, so lithium. I guess this is one area where I can say, I told you so, because integrative and functional psychiatrists, we've been talking about this for 30 years. I've been using it for 35 years. I learned it from Jonathan Wright, an integrative doctor trained at Harvard, who taught me about 45 years ago. So this is the element in the periodic table, lithium, atomic weight of 6.94, one of the third lightest elements on the planet. But it has profound implications for medication, lithium carbonate for bipolar disorder. As the element, it's used in, well, fireworks, but probably more importantly to us is cell phones, electric cars, batteries, airplanes. Almost every aspect of technology is dependent on this mineral. But my world in integrative and functional psychiatry is supporting and educating clinicians on nutritional lithium. What is low dose lithium orotate and how do you use it in a clinical practice? I will tell you emphatically, again, working in hospitals, working in integrative clinics, nutritional lithium has been the most profound clinical tool that I've had in my practice. And I know this because I've gotten the more thank you notes from spouses and teachers and parents and kids understanding how to do this. So we got to start with the drama first. And this was in the summer of 2025. If you have not read this article, Promise me you'll find it. I think it's open source. It's Nature, August 6, 2025. A group from Harvard published this. New Hope for Alzheimer's. Lithium reverses memory loss. This is just a summary, but it is just profound and amazing. Okay, first of all, we, as in the group at Harvard, I was not involved. Um, they took brains from a brain bank here in Boston and they dissected and they looked at 50 metals and they found lithium. Yes, the metal lithium in the Earth's crust was low, the only element low in the brains of those with Alzheimer's. Okay. Then they looked at a mice model, genetically bred mice that developed plaques and tangles, the Alzheimer's pathology, very, very early on in months. So what they were able to demonstrate is three pretty amazing things. One, when they did get Alzheimer's, the plaques and tangles, they gave them lithium orotate, the nutritional supplement that we've been recommending for 30 years. It broke up the plaques and tangles, excreted in the urine, and the Alzheimer's pathology in the mice improved. It broke up the plaques and tangles. Now, they tried lithium carbonate, and that didn't penetrate the plaques and tangles to break it up. So lithium carbonate did not work. Okay, number two, they fed these poor animals a lithium deficient diet, and they watched this group of animals. These mice develop Alzheimer's more quickly than their typical genetically bred rapid onset of plaques and tangles. So a lithium deficiency diet stimulated this. And then they gave lithium orotate, was able to prevent the onset of plaques and tangles. I mean, you have to read it. It's not that complicated. There are a few complicated graphs, but it's written well. The conclusions are truly mind-boggling. Everybody who was kind of saying lithium orotate was unsafe, most of our traditional psychiatrists, all the newsletters, all the journals, all the psychiatrists who were mostly funded by our pharmaceutical buddies, they for years have been warning people lithium orotate is dangerous, even though none of them, and I know many of them, never prescribed it, never read anything about it, never asked the hundreds of us that have been doing it for 30 years, but they declared it dangerous. And all of a sudden, when this article came out showing it was the only form that reversed Alzheimer's, they had to say it was a great study and more research needs to be done. But it just put lithium orotate on the map. If you're not familiar with lithium, it was around since the Earth's formation. It was actually one of the first three elements in the Big Bang. So that was 14 billion years ago. The Earth was formed maybe 4.5 billion years. And this is lithium salt in the Earth's crust. It gets broken, it's from the rocks into the water supply. We get a little from our food supply, but most of the lithium that you and I and our ancestors have gotten over the last million years of some form of humanoid civilizations have been through drinking water, tap water. Remember that word? Because most of the lithium is filtered out of all these double reverse osmosis, triple filtered water. So we're getting less lithium than before. And, we have courses, we have a 2-day conference. Many of I've been studying this for a long time. I've written a couple books. I got a new one coming out. So Psychiatry Redefined is a lot on lithium, but the punchline, I just want to share with you the research is overwhelming that lithium as a pharmaceutical is anti-suicidal, That's been known for 40 years and reconfirmed in new research in 2025. And then my appreciation of low dose lithium. This is looking at over 3 million individuals. We have studies across the globe, low lithium in the drinking water associated with higher suicide rates in those communities. Okay. Lithium also decreases mood swings, irritability, impulsivity, and aggression. This is the world that many of us travel in because this is where our patients are walking in. And when you think about impulsivity and irritability, it just cuts across pretty much most of the work that you and I do day in and day out. The impulsivity, I don't have a lot of slides on, but think of addiction, trichotillomania, any kind of compulsive behaviors. Lithium is a standard treatment. But I just want to talk about irritability for a minute because it doesn't get discussed enough. It's only mentioned under borderline personality in the DSM and DMDD, disruptive mood dysregulation disorder, nowhere else in the DSM. But it has profound implications for outcomes. We have research studies with kids, irritability as an infant, as a young child, and then these kids are followed 15, 20, 30 years, one study, higher incidence of depression, anxiety, and suicide risk. So irritability is kind of an important symptom. And I will share with you now that irritability is no research, my clinical 30 years of observation, a functional lithium deficiency. Think about it cuts across depression, ADHD, road rage, autism. We have a psychiatric medication, antipsychotic, Risperdal, not approved for autism, but approved for the irritability with autism. So I don't know about you, but I've seen these 7-year-olds put on Risperdal, gained 100 pounds, high prolactin, metabolic syndrome, by age 10. Irritability associated with Alzheimer's, conduct disorder, aggression, anxiety, addiction. These are all clinical disorders where nutritional lithium has been incredibly helpful. I am stressed the low dose lithium. People are getting carried away and starting with 5 and going 10, 20, 30 milligrams. I start every child on 1, every adult on 2 milligrams. So Pure is the only one that has the 1 milligram. Again, the suicide studies, these were micrograms per liter in drinking water, have profound effects. The lithium orotate, some people find calming after a day or a week, but its benefits for the prevention of suicide, for the prevention of Alzheimer's, and for neuroregeneration is small amounts over time. Okay, so don't get carried away with these high doses of lithium. Okay, the last thing I just want to kind of share a little bit about is, yeah, it's important. We are what we eat. We are what we don't eat. But we are what we absorb. And celiac disease is, as everyone is familiar, is an autoimmune disorder with intestinal villi destroyed and malnutrition across essential amino acids, fatty acids, vitamins, minerals. So you would think with this path of malnutrition, not dissimilar to our anorexics, that there'd be a high incidence of malnutrition affecting mental health. And the research is overwhelmingly yes, but clinically, there's no GI doctor, there's very few psychiatrists, very few primary care doctors can appreciate the significance that 50% at least of those with celiac disease present with no GI symptoms. They present to you and I as mental health professionals. They're fatigued, they're tired, they're depressed. And the research has just been overwhelming about celiac disease associated with depression, anxiety, dysthymia, pain, panic disorder. And these are there are multiple studies. I just picked a few here with 133 adults, 85 anxiety, 82 depression. Now you could say it's because they want their bagel and they're just frustrated about not having gluten. But if you do the blood work, like I have done for 30 years, these individuals with celiac disease are malnourished. They are low in iron, zinc, B12, and oftentimes many others, tryptophan in particular. There's a lack of absorption of essential nutrients for brain function. Okay, long study following kids, 13,000, childhood celiac disease, 19% increased risk of any psychiatric disorder. Long-term malnutrition affects brain function. The brain is our most metabolically active organ in the human body. Malnutritional deficiencies are going to affect brain function. And look at the wide range of risk disorders. So when we think of integrative and functional medicine, we just don't think of throwing supplements at patients. We think it as our medical colleagues have done for centuries, maybe. We have objective tests. We're going to look at your blood. We're going to look at your urine and stool or hair, and we're going to see, do you have antibodies? What about pernicious anemia? Antibodies to intrinsic factor, low B12. You're depressed, your panic disorder. But it's not due because you're fighting with your neighbor about a cherry tree on both lawns. It's because you don't absorb B12 and you have a B12 level of 140, and that is why you're depressed. Okay, more studies with kids. Um, and I guess if you don't test, how do you know? And it's hard to do this over the internet. It's hard to learn on Facebook. It's hard to learn on TikTok. It's better as we have some great conferences coming up. Um, there'll be a lot at Psych Congress in the fall. IMMH is in the fall. And we'll be at the APA. There's a lot going on. Vegas will be at Elevate, another H&P conference. So yes, you can learn, but it's hard to take it home. And that's why the fellowship has been so important to me, starting it years ago and now continue to teach because you learn what tests to take and to recommend and what tests might not be so relevant for a psychiatric patient. If you want to jump into this integrative world, and I know some of you from your comments are there, you can get overwhelmed with stool tests and neurotransmitter tests and mycotoxin tests, and then total environmental toxin and organic acids and fatty acids. And you go to Dr. A and they do these three tests, and Dr. B does these four tests, and these patients are coming to see us now with literally thousands of dollars of tests that I have to share with them are interesting, but kind of meaningless for your depression or not necessarily accurate. So we have to appreciate the role of testing. And my favorite picture that our psychiatric patients do not have to be kind of part of our educated guessing game. We can really do these tests. We can say, Johnny has an MTHFR variant, needs more folate, is low in magnesium, has a B12 of 250, which the PCP said is normal, that I'm going to say is contributing to the depression. And we treat that, and Johnny gets better quickly. So functional psychiatry, it doesn't really throw away anything but bad symptomatic-based medicine. It enhances every aspect of psychiatry. If you want to do TMS or ketamine, that's okay. But I gave a talk once because I had a series of patients um, who failed ketamine. They came to our hospital, failed multiple trials of ketamine, came to our hospital. We did our routine blood work and had a very, very low B12 and other micronutrient deficiencies. So there's no amount of ketamine that's going to help a brain that just doesn't have the fuel. But think what would happen if that person took B12 and iron and all those other nutritional deficiencies before the ketamine. So we don't exclude, we just augment the approach. We're adding tools to your toolbox. It takes time, takes energy and motivation, but mostly motivation to help your patients. So again, I'm confident that we don't have to push the ball up the hill. We have trainings, we have incredible faculty, and most important, I do want to share about the fellowship is the community. So you have thousands of clinicians interacting daily. I don't know how they have all the time in the day, but you're asking a question about a case and you're getting multiple answers that evening. People are helping each other, and plus we've paid faculty who are on the community listserv. So you have many ways of learning in Psychiatry Redefined. We have, again, 450 hours of content. You can jump to the schizophrenia course and learn about B3 and gluten and omega 3s if you want, even though the curriculum starts with depression. Um, you have office hours. I run office hours once a month. Someone else does it once a month, usually topic based. Mine are open. So you'll get, and then we get extra training in the lab test, organic acids, cryptopyrrole, fatty acids. And then as fellows, you have access to all the programs that we do during the year. So we have an ADHD program, we have a hormone problem, we have anxiety. These are all three sessions, really focused. And some people take it from the outside, but as fellows, you have access to all that material. It is a rich community. It is an exciting field. People sharing articles. I don't know how we can keep up with all these articles, but people are sharing these relevant articles for all of us to read, presenting cases as the faculty guides new clinicians through. Here's some of the programs that uh, we did the anxiety, but you have access to that. I'm doing deep prescribing, ADHD, and hormones are coming up. And these, again, all free. So this is me, my Finally Hopeful book, which is a functional psychiatry um, description of depression, is now available. And this book should be out in a few weeks. Updated lithium book called The Lithium Revolution. So this should be available on Amazon in a few weeks. And this is now where I'm focusing my clinical time, Finally Living Now. It's a virtual clinic. We're licensed in 50 states where we're doing functional psychiatry testing. We're doing the organic acids and the fatty acids and the amino acids. And we have graduates of Psychiatry Redefined, people that have been with us for many, many years now, working as a group, um, treating patients. So if you have stuck patients or complicated patients or patients that you want to refer, we're open and it's pretty exciting. So this is your job tonight. I appreciate the chat, and I'm going to get to the questions. So I see a bunch, if I can find them. But, if you're not sure, please schedule a call. Leela's on tonight. Cindy takes calls. They just know our programs. They've been with us for years, and they'll help you sort through if the fellowship is right or what other programs could be. We have short, long, many, many different learning styles, but I think where we're completely unique is a vibrant community of caring clinicians who want to help each other learn this material. Um, Someone asked about glyphosate, and absolutely think it is a contaminant that is a huge problem, hence better response to gluten in Europe. And there are tests where you can look at glyphosate toxicity. Oh, wait a minute. I didn't want to disappear. Okay. Oh, so Larry's case. Um, well, first of all, feeling better took 2 to 4 weeks. The amino acids are pretty incredible. He was on a number of medications, so I don't know how long, but it took months to get him off medications. I think the best book that I've written for professionals is Integrative and Functional Medicine for Antidepressant Withdrawal. It's going to be a specialty program for our clinic at Finally Living Now if you need someone needs some help tapering off. And then we have an intensive coming up. It's only 2 session intensive, but at least give you this guideline. I am quite convinced doing withdrawal protocols for 15 years that a functional psychiatry approach is the simplest and safest way to taper someone off medications. When I started talking about withdrawal, most people dismissed me. Many of the articles coming out started saying, well, patients should just stay on medicines forever. But now it's the in thing because patients pressured us. So now we just say, well, go slow, um, hyperbolic tapering. Well, of course you want to taper slowly, but it does not help everyone because you have to look at these nutritional deficiencies. So please, I encourage you, the fellowship doesn't work for you. Think of some of these shorter course like this withdrawal. I don't know the causes for these very low cholesterols. It's not dietary related because I have vegans who haven't eaten fat and their cholesterols are 200. When we're under stress or our body's under stress, like in anorexia, our body makes more cholesterol, right? Because our body wants more steroid hormones because we got to build up our fight or flight response. So usually it is genetic, and we don't really know the cause. Now, cholesterol lowering drugs, statins, have been shown to affect cognition, memory. There's a black box warning on statins. I don't think they've taken it off yet. So, memory impairment from taking statins, we've known that for years. Cholesterol goes down. And there's a book by Graveline. I encourage everyone to read it. If you're not convinced the concerns with statins, Graveline. He was a neurosurgeon. He was put on a statin, completely lost his memory, and he wrote a book about it. Yeah, the okay, so I'm glad there are a lot of questions about Larry because amino acid testing is one of the most important things I do as a psychiatrist, and not everyone does it, but it's just so important. It's usually 3 to 6 months of free-form amino acids and digestive enzymes with HCl, and it just depends on what else we're doing. Um, Oftentimes, this is getting a little carried away, but you need zinc to make hydrochloric acid. You need zinc to make all the digestive enzymes. So, if you have a zinc deficiency for whatever reason, you're going to have less acid, poor digestion, but eventually, if zinc is supplemented, you'll be able to get off it. But the free-form amino acids and digestive enzymes is usually 3 to 6 months. So there's no lithium blood testing that is accurate. The lithium blood test that we get in the lab is only for pharmaceutical doses of lithium carbonate. So everyone in this room, unless you're taking lithium carbonate, should have zero lithium in the blood. So we look at lithium in the hair sample, and then we have lots of clinical um, uh, just paths of how to understand how to use nutritional lithium. Please, that's a core part of the fellowship is understanding how to use nutritional lithium. Yeah, I mean, lithium, like every mineral, is has a unique role. Um, Someone asked me a question, what it does, and that's not a good question because I could go on for 6 hours. It is just pretty close to this miracle mineral, if you will. It affects the calming neurotransmitters like GABA and serotonin. It kind of dampens glutamate and dopamine. It is anti-inflammatory. It is an antioxidant. It is profound effects on a number of genes, particularly the transcription of brain-derived neurotrophic factor. It is a pleiotropic is the word, mechanisms of action in the brain. You could open a 5 milligram capsule and didn't take less of the lithium, but I'm not a huge fan of opening capsules. So we use DHA labs and Rupa labs to order these tests, and we go through all the testing in Psychiatry Redefined. So someone again asking what tests to prioritize, and I don't think there is a priority because if you prioritize, which I tried to do in the 90s, and everyone else does when they start, is how do you know what's the best test? You just don't know. I mean, if someone is iron deficient, you might be able to look at their pale eyes and make a diagnosis. But for vitamin D and B12 and most of our other micronutrients, we don't know. So the model that we teach in Psychiatry Redefined is that we do a wide range of testing. We look at genetic tests, we look at nutritional tests, we look at hormone precursors, pregnenolone and DHEA, we look at cryptopyro, we look at fatty acids. Because if you don't test, how do you know? And too many times you go to that conference, you sign up for that organic acid conference, and you spend the weekend, and it's pretty cool to see all these metabolites and their role in the body. And then that's all you do in your patients. And the organic acid is a great test, and it's required in every patient that we see. But there's only like 4 or 5 really home run markers for psychiatry. But if that's the only test you do, then you're just going to be treating off that test. And you're going to miss the low ferritin, the hypothyroidism, the low B12, the high cryptopyrrole, and the MTHFR variant. So the model, which obviously I can't share in an hour, but please, if you give us a year, you'll become an expert, is functional psychiatry. It takes time, takes motivation, but it is incredibly gratifying. As patients get better, they come off medications, there are less side effects to medications, and you get these genuine thank yous that I think in the polypharmacy world, you just don't get enough. So I hit, I think, most of the questions, and I really appreciate the comments in the chat. Yeah, the Lithium Revolution should be out in a few weeks. It's not up on Amazon yet, but the Finally Hopeful book is. So, Alila, unless you saw any other important questions that I missed, Um, I think we'll call it a night, and I just encourage everyone to schedule a call at your convenience. If you have questions for me, I'm happy to answer them. And if it's a program that doesn't fit for you, then please reach out to a colleague. I think the punchline is we can no longer wait to learn this information. Our patients know more than us. Kennedy is now demanding, I don't know how many hours, 40 hours of nutrition in medical schools, but that's a little late for most of us that had 5 or 10 hours. So we have to appreciate the role of micronutrients in brain function. We have to understand genetic individual differences. And when we pair that dance together, we can prevent this kind of aggravated fight. If someone genetically prone to develop celiac disease and then eats a lot of gluten and has that reaction, they become malnourished and potentially depressed and anxious. So again, it's the beginning of our recruitment. We have lots of stuff going on that's free for fellows, the ADHD, the antidepressant withdrawal, and then you're part of the community. And I really encourage everyone to reach out and let us know if there are specific programs that will be of value to you. So have a great night and thank you.